Let's talk about prostate cancer standard radiation treatment for both brachytherapy and external beam treatment. Dose escalation studies note that there are 6 trials that show a 10 to 20% increase in biochemical progression-free survival, but not overall survival with dose escalation. The first is PROG by Anthony Zeitman, published in JCO in 2010. This is treatment with photons up to 50.4 gray or 5040 centigrade. Then they got a proton boost of either 19.8 GYE or 28.8 GYE, so a difference of only 10, or 9 rather. 19.8 GYE or 28.8 GYE, there was an increase in biochemical disease-free survival with the boost up to 79.2 versus 70.2 in both low and intermediate risk, but there was no difference in overall survival with PROG, and there was increase in grade 2 GI toxicity, which was significant. The second is Debbie Kubin's trial from MD Anderson, looking at 70 versus 78 gray for an isocenter dose. There was no difference in overall survival. There was an improvement in 8-year FFP, freedom from progression, and decreased distant METs, but increased rectal toxicity from 13% with 70 gray to 26% with 78 gray, but bleeding was reduced with a V70 less than 25% of the rectum. Third trial is RTOG 0126, intermediate risk 3D conformal or IMRT. They either got 70.2 gray or 79.2 gray, powered to detect overall survival difference. There was no difference in overall survival, but biochemical relapse-free survival, salvage treatment rates, and distant METs were better with dose escalation. The last and most recent is FLAME, intermediate and high risk, 77 gray and 35 fractions versus less than or equal to 95 gray SIB. Focal boost to MRI disease plus 77 gray as feasible with priority to OARs. 95 gray was achieved to the DIL, the dominant intraprostatic lesion, in 20% of patients. Focal SIB to the GTV MRI nodule improved 5-year biochemical disease-free survival without an increase in toxicity. Let's talk about brachytherapy planning and treatment. This is going to be your highest yield. Pre-plan. 1 week prior to the implant, bring the patient in for sizing of the prostate, determination of favorable anatomy, meaning no pubic arch interference, and creation of a pre-plan to order the seeds. OR with general anesthesia, dorsal lithotomy position and footrests, prep the perineum with betadine, insert a Foley catheter, and then infuse 120 cc's into the bladder. Make sure the transrectal ultrasound is secured to the table, then insert the transrectal ultrasound into the rectum. Make sure that the prostate is centered on the template such that the base is at 0. The rectal wall is aligned at row 1. Capture transverse images at 5 mm intervals from the base to the apex, including a cut above and below. Note the prostate length and volume while doing this. Contour the bladder, the prostate, which should have a 3 mm margin anteriorly and laterally, and a 5 mm margin superiorly and inferiorly, 0 margin at the rectal interface. Anterior rectal wall. Order seeds with 10% extra seeds. Again, pre-plan. 1 week prior to the implant, bring the patient in for sizing of the prostate, determination of favorable anatomy, meaning no pubic arch interference, and creation of a pre-plan to order the seeds. Take them to the OR with general anesthesia. Put them in a dorsal lithotomy position in footrests. Prep the perineum with betadine. Insert a Foley catheter and infuse 120 cc's into the bladder. Make sure the transrectal ultrasound is secured to the table. Insert the transrectal ultrasound. Make sure the prostate is centered on the template such that the base is at 0.0. The rectal wall is aligned at row 1. Capture transverse images at 5 mm intervals from the base of the prostate to the apex, including a cut above and below. Note the prostate length and volume. Contour the bladder, the prostate, and the anterior rectal wall. The prostate should have 3 mm margins anteriorly and laterally, 5 mm superior and inferior margins, and 0 margin at the rectal interface. Order the seeds with 10% extra seeds. On the day of the brachytherapy procedure, repeat the setup as above. Match the intraoperative images to the preoperative images using the seminal vesicles in the base of the gland. Use 18-gauge needles, typically 16 needles are used, inserted into the template with 1 centimeter spacing through the perineum under ultrasound guidance to ensure adequate depth. Placed anteriorly to posteriorly. Stranded seeds are deposited from preloaded needles. The peripheral loading technique is used to minimize urethral dose, meaning you use more needles on the periphery, and again, 1 centimeter between needles. While you're inserting the needles, visualize them in the desired plane by rotating the bevel, which can help visualize them on the ultrasound. Verify the position with sagittal and transverse ultrasounds. Place anterior seeds first to avoid distortion of the transrectal ultrasound, and in case pubic arch interference is present, you figure that out ahead of time. Keep a 5 millimeter margin for the posterior needles to minimize rectal dose. Intraoperative plain film should be done to make sure the seed count is correct, and post-procedure cystoscopy with irrigation. If the seed count is not correct, get a chest x-ray to rule out seed migration. You want to do a post-implant room survey. The patient should be discharged after urinating, and you discharge them with Flomax 0.4 milligrams daily, NSAIDs, and ciprofloxacin 500 BID times 3 days. 30 days after the implant, you get a CT scan for dosimetry. And when you're doing brachytherapy with EBRT, it's okay to do 4 months or 1 to 3 years of ADT, shorter. Let's go through day of setup one more time. Repeat setup as above. Match the intraoperative images to the preoperative images using the seminal vesicle and the base of the gland. 18 gauge needles, typically 16 needles, are inserted into a template with 1 centimeter spacing through the perineum under ultrasound guidance to ensure adequate depth. Place anterior to posterior. Stranded seeds are deposited from preloaded needles. Peripheral loading technique should be utilized to minimize the urethral dose, meaning more needles are in the periphery, and place 1 centimeter between the needles. While inserting the needles, visualize in the desired plane by rotating the bevel. Verify position with sagittal and transverse ultrasound. Place your anterior seeds first to avoid distortion of the transrectal ultrasound. In case pubic arch interference, you figure that out ahead of time. Keep a 5 millimeter margin for the posterior needles to minimize the rectal dose. Intraoperative plain film to make sure seed count is correct, and post-procedural cystoscopy with irrigation. If the seed count is not correct, get a chest x-ray to rule out seed migration. Do post-implant room survey. Patient should be discharged after urinating with Flomax 0.4 milligrams daily, NSAIDs, and ciprofloxacin 500 milligrams BID times 3 days. Let's now talk about dose for LDR. Your two isotopes are iodine-125 or palladium-103. Iodine-125 has a half-life of 60 days. The source activity is 0.5 millicurie. Again, iodine-125, half-life 60 days, source activity 0.5 millicurie. Alone, the dose should be 145 gray. I remember this mnemonic. Take the isotope number, which is 125, and add 20 for alone. 125 plus 20 equals 145 gray. Combined with external beam radiation, the iodine-125 dose is 110 gray. So again, iodine-125 alone is 145 gray. Combined with EBRT is 110 gray. Palladium-103 has a half-life of 17 days. Alone, it should be 125 gray. Again, trick, take the isotope number, which is 103, and add 20 for alone. So 103 plus 20 gets you 123, which is around 125 gray. Combined with EBRT, it's 100 total. Dose, LDR, iodine-125 alone is 145, combined with EBRT is 110. Palladium-103 alone 125 gray, combined with EBRT is 100. Dose for HDR, iridium-192 has a half-life of 74 days. Alone, you do 9.5 times 4. Combined with EBRT is 9.5 times 2, separated by 1 to 2 weeks. Again, iridium-192, half-life 74 days. Alone, 9.5 times 4. Combined with EBRT, 9.5 times 2, separated by 1 to 2 weeks. Pre-plan. The goal is to cover 100% of the prostate plus a 3 millimeter margin with 100% of the prescription dose. 200% lines are minimized. The dose to the urethra is kept below 150%. The rectal V100 is less than 2 cc's, and you want to peripherally load with approximately 75% of the total activity of the implant at the periphery of the gland. Again, goal is to cover 100% of the prostate in a 3 millimeter margin with 100% of the prescription. The 200% isodose lines are minimized. The dose to the urethra is kept below 150%. The rectal V100 is less than 2 cc's. Peripheral loading technique with 75% of the total activity of the implant at the periphery of the gland. Brachytherapy DVH. Your post-implant dosimetry 1 month after the procedure. The prostate shrinks and it makes the implant look better, but the urethra dose look worse. Target coverage is as follows: V100, meaning the volume receiving 100% of the dose is greater than 90%. V150 is less than 50%, V200 less than 20%. That's actually pretty easy to remember. It's like V150 less than 50, V200 less than 20, and then V100 greater than 90. The dose uniformity, you want to minimize hot and cold spots. D90, meaning the dose that 90% of the prostate receives, is greater than 95% of the prescription, preferably 100%, meaning 145 gray. D90 less than 125%. So again, D90 greater than 95% of the prescription, but D90 less than 125. Your OARs, your urethra, V125% is less than 1 cc, V150% less, or should be 0 cc's. Rectal V100 should be less than 1 cc. Again, OARs, urethra, V125% less than 1 cc, V150 should be 0 cc's. Rectal, V100 is less than 1 cc. Toxicity of brachy, acute GI risks are higher. 40 to 50% have grade 2 acute GU toxicities. Acute GU is higher. 40 to 50% of grade 2. Risk of acute urinary retention is AUA score plus 10%. This presents as either an inability to urinate or significantly increased frequency and or incontinence. Treat, you can place Foley catheter. You can increase the flow max dose or start steroids, but this will often resolve on its own as the swelling subsides. Acute GI toxicity is lower. Brachytherapy contraindications are an AUA or an IPSS score of greater than 15. Prostate size or anatomy that are not conducive to brachy are a prostate volume greater than 50 cc's or less than 15 cc's, a patient with pubic arch interference or a median lobe hypertrophy or T3 disease. Likewise, a prior TURP with a large defect would be a contraindication of brachy. Safety guidelines avoid pregnant women and children for 1 half-life of the isotope used. You can have PSA bounce between 12 and 24 months, and it can be up to a few points. External beam radiation planning and treatment. If they're on ADT, you can do SIM 4 to 6 weeks after starting with plan to start after approximately 2 months is classically what was done, but now we can actually start ADT concurrent with radiation. SIM, ideally, you'd have 3 fiducial markers placed approximately 1 week prior if you're going to do SBRT. Otherwise, you want empty bowels. Bowel prep beforehand with an enema would be ideal. A full bladder, have the patient drink 16 to 24 ounces 30 minutes prior to their CT simulation. Oral contrast for small bowel. You want to sim supine with knee or foot lock immobilization, and then place the isocenter in the center of the prostate. Volumes for prostate and seminal vesicles only. Not whole pelvic RT, which we'll cover later. Your CTV is your prostate and your proximal 1 centimeter of the seminal vesicles. Lateral border should be the puborectalis muscle. Inferior border should be 1 centimeter above the penile bulb. Posterior border is the prostate and rectal interface. Your PTV should be your CTV plus 6 millimeters with 5 millimeter expansion posteriorly to avoid extension to the rectum. Your dose conventionally was 79.2 gray and 44 fractions, but we don't do that anymore. Hypofractionation, you can do 70.2 and 26 fractions, or more commonly 70 gray and 28 fractions at 2.5 gray a fraction, or 60 gray and 20 fractions at 3 gray a fraction. This is okay for all risk prostate cancer patients with ADT. We need long-term data. The best evidence is behind 60 gray and 3 gray a fraction. If you're doing a brachytherapy boost, then after 40 or 50 gray of external beam, you give iodine 125, 110 gray, or palladium 103 at 100 gray. Your daily setup, daily KV match with fiducials, weekly cone beam CT to check bladder rectal volumes. SBRT is 7.25 gray times 5 fractions every other day, which goes to 36.25 max. 5-year biochemical relapse-free survival, 95%, 84%, 81% for low, intermediate, and high risk. The dose constraints for RTOG 0415 are a bladder of V74 less than 25% and a rectum V69 of less than 25. The dose constraints for 60 and 20 are a bladder V60 less than 5%, V40 less than 5%, rectum V20 less than 85%, V50 less than 27%, V60 less than 0.1%. For SBRT, the D0.03 cc should be less than 38.06 for the rectum and the bladder. In terms of plan evaluation or dose constraints, rectum, if you're shown a DVH, pick the one with the smallest amount over 70 gray. Rectum V75 less than 15, V70 less than 20, V65 less than 25%, V70 less than 10 cc's. The bladder V75 is less than 20%, V70 less than 25%, V65 less than 30%. Penile bulb, mean should be less than 52.5 gray. You have options. If you're not meeting your constraints, you can reduce the dose to 75.6, 4 to 6 months of ADT to shrink the prostate, minimize the PTV by using fiducials and daily cone beam CT, use a hydrogel spacer. Grade 2 GI toxicity is 0% versus 6% on SpaceOAR. If you're treating the whole pelvis, bowel bag should be V45 less than 200 cc's with a max of 50 gray, and femoral heads to the ischial tuberosity should be a Dmax of 45 to 50 gray. Hypofrac, again, rectum V69 less than 25%, bladder V74 less than 25%. This shows a cumulative DVH. The dose of the PTV is in red here. D90 less than 125 is a surrogate for post-implant D90 less than 180. Post-implant D90 needs to be greater than 140 gray. R100 less than 1 cc is a surrogate for proctitis. These blue marks here show V100 greater than 95%, V150 less than 60%, V200 less than 20%. Some stricter rectal constraints may require less PTV or lower coverage posteriorly or SpaceOAR to achieve. Again, hypofractionated CHIP regimen, this is probably the one you should remember. Rectum V20 less than 85%, rectum V30 less than 57%, rectum V40 less than 38%, rectum V50 less than 22%, rectum V60 less than 0.01%, bladder V60 less than 5%, V48.5 less than 25%, V40.8 less than 50%. Let's go through this one more time. Hypofrac, CHIP, rectum V20 less than 85%, V30 less than 57%, V40 less than 38%, V50 less than 22%, V60 less than 0.01%, bladder V60 less than 5%, V48.6 less than 25%, V40.8 less than 50%.